in 5, 4, 3. Dear viewers, welcome you all to our show OSA, that is Orthopaedic Solution Academy. Dear viewers, today our topic is bone healing, non-union and grafting, an evolving concept. And the presenter is the very prestigious Professor Hemant Sharma sir from Hull University, UK, and he is the president of BLRS. I would like to request Professor Hemant Sharma sir to join with us.
Hello, good afternoon.
Good afternoon, sir. Thank you very much for joining with us.
Thank you.
Dear viewers, we have 3 learned academic experts from all around the world. One of them is the legendary Ilizarov surgeon, Professor Mofakhkharul Bari sir from Bangladesh. I would like to request Professor Mofakhkharul Bari sir to join with us.
Good afternoon, everyone. Good to see you, Hemant.
We have Professor Omar sir from Kurdistan, Iraq. I would like to request Professor Omar sir to join with us.
Good afternoon, everyone. I am more than happy that I meet also Professor Sharma, Hemant Sharma. Thank you so much for everyone.
Thank you very much, sir. Dear viewers, we have another learned academic expert from Kurgan, Russia, Professor Novikov sir. And I think he will join in the coming part of our program, as well as Dr. Shamsul Huda sir from Patna, India, and he will also join with us in the coming part with our program. Dear viewers, this program is also live in the OrthoTV Global. You can connect us with the OrthoTV Global also. Now, I would like to request our honorable speaker, Professor Hemant Sharma sir, to start his presentation. Sir, would you please share your screen and start your presentation, sir?
Can you see that?
Not yet, sir. It's coming. It's coming, sir. Yeah, it's visible, sir. It's visible, sir.
Lovely. So, first of all, my gratitude and thanks to Bari, who's an old friend, and Bangladesh Limb-Recon surgeons and team 2, and Dr. Tanvir for organizing everything. And it is a great pleasure to be part of this educational event. Hull, if you look at it, is in north of England, and if you looked about 900 years ago or 800 years ago, it was probably a marshland at the end of the river and near the sea. And the town was established a long time ago, and this church was built in 1285. And at that time, it was a strategic importance because of the of the links with the Scandinavia for exports, and therefore the king recognized the city and called it Kingstown upon Hull, and that is the name came, the Kingston upon Hull, which is the current name. We have a lot of things, and we had the longest single-span bridge in the world. This used to be the longest. It is the 3rd longest now, almost 2 miles long. And it's quite a spectacular view here. Anybody can come to Hull, you must visit this. Of all the people and all the things in Hull, we are the most proud of, and is William Wilberforce. He was the member of Parliament, and he was quite active against the slavery. And because of his efforts, and obviously some more people around the country, the Slave Trade Act was passed in the Parliament in 1807, and just before his death, or around about that time, Slavery Abolition Act was passed by the British Empire, and all slavery was stopped within the British Empire. And he was son of Hull, and we are probably the most prominent citizen of Hull till today. We are a big hospital. We are about 1,500 beds. We have our own university, medical school, and is a massive oncology center. And we are based at 2 sites. The other thing which you might not know is There was a chap called Thomas Smith. He used to sell stuff to hospital, cod liver oil and few other things, bandages, other things to hospital. And his business grew quite big. And when he couldn't cope, he asked his nephew, Herato Smith, to join him. And that is how, in 1896, Smith nephew was born. So Smith nephew is based in Hull, and all the things you use, especially the Ilizarov bit, all came from Smith nephew. Now that has moved to US in Memphis, but the wound division is still in Hull, and all the dressings and bandages you use from Smith nephew are all made in Hull. My name is Hemant Sharma, and I work in the Hull University Teaching Hospitals, and I run a limb reconstruction and bone infection unit. And today I'll be talking about bone healing, non-needle, and a little bit about grafting, not a lot, and how the concept is evolving and how we are changing our understanding for it. So I hope that by end of this talk, we'll be able to discuss healing in relation to mechanical-biological concept and strain theory, a touch about bone grafts, and how we are thinking, and how whole concept is evolving and changing, and how hopefully it will help some of the upcoming surgeons through this talk. So I'll start with this example. This is a patient 3 months post-surgery. If you look at the fracture, it is trying to heal. If you look at the overall fixation, it's not ideal, but it's trying to heal. And the question comes in at this stage, what do we do? Do we just sit and wait? Do we do something about it? If you ask me, at 3 months, there are clear signs that is very likely, we may be lucky, but it's quite likely that we may go on to non-union despite the callus formation. Because I think the principal problem here is the stability. Because if you look at it, it is trying to heal. There's a single screw. And overall, if you look at the concept, it is not very well fixed at isthmus. So you got a long working length, and there's a clear instability. It may heal up, but my feeling is it won't. And that's what happened. When in 17 months down the line, it is a non-union. Luckily, nail hasn't broken because there's some callus formation, but there's a non-union, which we could have predicted, and possibly the way we have fixed it could have prevented it, because bone is trying to heal. Bone, the default position for bone is always to heal. Now, if you look at the bone healing, actually what do we need? We need the biology, which is the soft tissue vascularity and all the cells. And if you look at it, biology actually is almost never an issue. Biology is always there. What we do with the bone, that is an issue. And therefore, the stability and the mechanical environment comes into play, and it's very important to recognize that. Now, if you remember Perrin's work in 2002, which he published, he said the strain bandwidth should be less than 10%, around about 2 to 10, depending on if you're dealing with a laminar bone or the woven bone. In addition, we also need bone to have contact, because if bone is not reduced, there's no contact, the chances of healing is much less. And that actually bone contact and reduction of the fractures actually improve the mechanical environment. So all the things are interrelated. If you look at the current practice and how it works, so if you look at it, you have a bone which fractures, there's a bleeding, there's a proliferation, there's some callus formation, and it remodels and heals. If you look at the strain point of view, in initial phases, there's 100% strain because bone can move without breaking the granulation tissue. And as callus forms, it becomes progressively stiff, and then when it fully healed and remodeled, it is just completely stiff. How we use a device. So whatever we use, nail or a plate or the frame, what we do is we make it very stiff in the beginning. We fix it really well. And when the callus forms and remodeling comes, we dynamize, we take the rods out in the frame, or do the loading, and in the nails we take the screw out, just to dynamize and bone, so let the bone take the more load, and we feel that will help it heal. This is the current practice, and this is the current theory. And this is the same thing if you see as bone healing, and this goes through, it is presented in a different way. If you look at the Wolff's law, long time ago, Wolff said the bone structure is and changes are responsive to the mechanical environment. So how we load the bone will depend how the bone heals and how strong it becomes. And this is from the Powell's work, recently published by Veda. And it basically says that the mesenchymal stem cells differentiate, and the differentiation depends on the mechanical forces. And that we well know in a lot of animal studies and in the work otherwise, is the mechanical forces which decide what does the MSC become and what it forms. That we know very well. And this is just the pictorial representation of that mechanical forces. If you remember the paper which Ken Wright published, and what he said was from Oxford, and which we all follow all the time, is that micromotion helps in bone healing. So that we know very well. But he also said something which we completely ignored in that paper, was that he said, or the author said, the rigidity of the fracture should be increased to optimize fracture healing process in subsequent weeks until fracture heals. And basically, the idea is we need to optimize the strain as the fracture heals. So if it becomes from a low strain fracture to a high strain, then we need to do something to change the mechanical environment to optimize the strain and to reduce the strain so it stays below 10% and between 2 to 10%, so it heals. And this is the parents' work again, which shows that a lamellar bone and the woven bone can work within a certain strain environment. If it is more than that, then it will lead to non-union. If it is too stiff or you're too lax, you will end up in a non-union, and that we know. So if you look at this type A normal transverse fracture, the strain environment is very high. It's a very, very high strain environment. As compared to if you see a comminuted fracture or a type C fracture, here, because there are multiple fragments, the strain is spread out, and is basically, it becomes low strain environment. And what we need to is, we need to optimize the strain in this fracture and this fracture so the bone heals. And there's some further work published in 2016 by Nottingham Group, and Elliott published it. And basically what they say, we need to be between point B and point C. Because if beyond point C and beyond point B, bone will not heal. Either bone will form or resorb, but we need to manage the mechanical environment, so we keep in between point B and C so the bone heals. Either side of it is not good for the bone. Now, in 1998, Carter coined this term mechanicobiology. And basically what he said was the study of mechanical and physical conditions, how we study them regulate the biological process. And actually, it was forgotten concept until recently, that in last 2 to 3 years, we have started looking at back and looking at it, how bone is healing. So I would urge you to consider all bone healing in view of environment, of the strain environment, and look at it as biomechanical problem. And in our clinical practice, we give so much emphasis on the biology. We do bone graft, we do this, we do that, we do BMP, we do stem cells. But actually, how many of us actually talk about the mechanical stability? And as I'll show you in further slides, that biology is rarely an issue. In almost all non-unions, almost all, it is the mechanical environment which is a problem which we need to tackle. But the problem is that once we know something, we think we know, we have entrenched views and we just focus on that. It is very hard to change our views and change how we think, because we tend to cling on what we know. But I urge you to think differently. So let's look at the non-unions. Atrophic non-union, it does not exist. There is nothing you can prove there's a atrophic non-union. It is only thing is a low strain environment. And if you look at the histological sections, you will know that it actually, the blood vessels are there. It is a misconception that atrophic non-union does not has blood supply. And there's plenty of studies, in animal studies mainly, which shows that there's a vascularity is similar to the hypertrophic non-union, but it just is slow in the process. And because the mechanical environment is not right, it is not manifesting. So if you look at it, how we work, atrophic non-union, we do bone grafting. Hypertrophic non-union, we make it more stable. And actually, if you look at it, it is a low strain, high strain environment. So do we need to do bone graft? Actually, for non-unions, no, we don't. The only indication for bone grafting is when there is a bone loss, or in a gap non-union where there's a low strain environment where the contact is not there, and we think bone grafting will increase the contact area and change the strain environment. It is only time we need to do bone graft. But otherwise, in any non-unions, we do not need to bone graft. Certainly, we don't need to bone graft the hypertrophic non-unions. And I'll show you this example. This is a 60-year-old gentleman, non-smoker. And this is, he has a nail which is clearly failed. And when he's referred, there is a gap. You can see there is a gap, right? But do we bone graft? No, we don't. Because this is, all it needs is a strain optimization and change in that, and that will heal the bone. So you take the nail out, put in a frame, gradually collect the deformity, simple distraction, and you get it straight, and it heals. Now, can this done be with any other device? If you can do with any other device, it will work equally well. I don't do femoral frames, and I probably do, in the last 5 years, I've done one femoral frame because very uncomfortable for patient, but this is one indication which I will do a femoral frame. There is very, very few indications for a femoral frame, but this is one indication. Because you need to optimize, so you don't open the non-union side, don't do anything, it will heal. And here, we think it's a tension osteogenesis, which it is, but we have changed the mechanical environment, which has helped us heal. And Ilizarov provided that. And this is an example where we need bone grafting. And it is a defect non-union. This is the fracture in a 25-year-old gentleman. And when we see him, we see there is a clear gap. It will never heal. It doesn't matter what we do. So here we bone graft him, and it heals in time. And it fills up, he's fine. And I've just recently seen him 10 years down the line that we just changed the nail because the nail was very loose. So we need to increase the mechanical environment by putting in stiffer nail, bigger nail, and then bone graft. All what we're doing is change the optimizing the strain value, but also eliminating the gaps, and it will heal. But there are certain indications which you could do differently. This is a young 27-year-old smoker. Here, if you see, it is a low strain environment, right? It is a comminuted fracture. It's a big butterfly. You put in a simple frame, hoping it will heal. It healed at some point, but actually it didn't. He got fed up of the frame. So we said, okay, we take the frame off, give him a frame environment, a frame holiday. And do we bone graft? You can argue both way. You do or you don't. I'd suggest you don't. It was an old. It is a patient I dealt about 10 years ago. So I bone grafted him. But if I do him now, I will not, by understanding more about biomechanics, I will not bone graft him. So here I put in 2 cannulated screws, so two lag screws, put a neutralization frame. And if you see, I have put in a 4-ring frame because I have optimized the mechanical environment because I thought 2-ring frame was not enough. And it healed quite nicely. Now, if I have this patient now, I'll leave this frame, put 2 lag screws, and add a ring on each side and do the same thing, and it will heal it very quickly. So how we approach things is different. What we have for bone grafting, autograft is the most common. So in autograft, the probability, there's a problem with the complications. So one of the things we use is a reamer irrigation aspiration system. So we ream the medullary canal and collect the bone graft. From the complication point of view, if you look, the morbidity is similar between the two from the iliac crust bone graft and the RIA, but we get slightly more volume from the RIA. This is the picture from theater, but the bone graft has more complication rate, which we know, so we try to avoid it if we can. So, but if you have to do bone graft, autograft is the best option. Other options, we know what we need in a bone graft, so I won't tell you that. It is quite common, so this is a common knowledge, so I won't discuss that. But what I say is, there are a number of bone grafts coming. Autograft is standard. I wouldn't suggest you use allografts with a lot of problem. If you have to use it, then don't use a bulk allograft. Use a bone mill like what we use for the revision arthroplasty, and then mix it with autograft and some BMP or BMAC and use it. We use quite a lot of BMAC in my practice, and I never use this as a synthetic bone graft in my practice. But some things are available for you. The new things coming out is the scaffolds in synthetic, and that with the bone marrow aspirate or the BMAC or the stem cells seems to give reasonable results. So as I said, don't use allograft. If you use it, it is use a bone mill and make it small pieces because the absorption of the bulk allograft is bad. So we don't use that. And the level of evidence is quite poor in the allografts. Calcium phosphate, we can use it, but as I say, I use it of trauma just for elevation in the plateaus and pylons and other cases where it is absorbed in 8 to 12 months. So I use an injectable one to provide the support, and this is what I use. And the reason I can do it is I can use with about 2 centimeter incision, I can fix plateaus and do that. Scaffolds is something new, which is, well, it's not new, but it's coming on and it's quite useful. It depends on the porosity and the porosity percentage, and we need on the pores and how because bone can grow into the pores. And there are a number of things we need for that. And when you use the scaffolds, remember, not all scaffolds are the same. The pore size is important, and the larger the pore, the better is the osteogenesis, and the ingrowth is better. So pore size is quite critical. Along with that, pore percentage is important because that will depend if in ideal pore percentage, they can bone ingrowth is much better. So that's just a little bit about it. But as I said, I won't go a lot into it. Is a completely separate discussion and topic. Let's come back to bone healing again a little bit. The other concept is the dynamization. And there's a lot of animal and clinical studies, and they are contradictory, inconclusive, and it fails to demonstrate any benefit in bone healing. And when I say dynamization, it's like removal of the screws in a nail. It is the most misunderstood concept. It's based on a flawed theory. And in principle, what it does is, it just is based on the principles of the biology. It ignores the mechanics completely. Now, if you look at this fracture, it is nailed 3 months down the line or 6 months down the line. In this case, somebody removes the screws. They pay no attention to the mechanics, and all it did 14 months down the line is still a non-union. And I will urge you, the mechanics should be the part of the planning, right? And in our current practice, we give biology disproportionate prominence. Biology is important, but it is usually, as I said, not a problem, and mechanics should be given equal, but preferably more importance. How will I deal with this at 6 months? If I think the mechanics is a problem, which it is a problem in this case, you can either re-nail it with a larger nail or just put a simple plate here. You put a 4-hole plate, unicortical, bicortical, change the strain environment, and it will heal. It's a different way of looking at things. And this is the X-ray I showed you in the beginning. Here again, if I see this patient at 6 months, I add another screw and I put in a plate here. And this will heal. It is a day case procedure. You don't need to bone graft. It takes you half an hour and minimal blood loss. If you see this patient a long time down the line, and then what you will find is you will do much bigger procedure. And let me show you this another example. This is the injury, right? Again, huge butterfly fragment, low strain environment. This is how it is fixed. 2 screws and distally, and this is a gamma nail. So you to get the purchase from the head. Now, if you look at it, it might have a purchase here. I'm not too sure. Only purchase is here and here. And its working length is this much. In an environment which is unstable, it's a low strain environment. I give you that. But what will happen? Very high chance of it's going to non-union. This is what happened. 10 months down the line, screws broken, and the distal it's healed, which often it does, and it's a non-union. In addition, it has got an internal rotation. So here what you do, this is a type C fracture. Now it is being converted into type A fracture. From a low strain environment, this has become a high strain environment. How do we tackle with this? So what you do is, so this patient had an internal rotation, so I have to derotate the bone. I derotated the bone, and then I re-nailed with a much thicker, larger screw. So I have a purchase here. I have some purchase here, not a lot. But in addition, I put in a plate because I was not convinced that the purchase I'm getting here is good enough. So my working length could still be as long as this. I need to change the environment. This is a high strain environment. I need to change it to low strain environment. So I put in a nail, a thick nail, and I put in a plate on top of that to give it added more stability. And 6 months down the line, it is healed, just a little bit left, and it is healed. So these are the kind of things we need to look at it, not just the bone grafting, not just each fracture is different. Each fracture must be looked differently and then tackled individually on its own merits. And we are changing our practice more and more, and rather than just standard renailing or bone grafting, we just changing the environment. In this patient, if this is not a rotational problem, you can consider putting 2 lag screws in this and leave the nail, the original nail. It will still do the same job because you're changing the mechanical environment. Then the screws were broken, so we may have to put a new screws or change the nail. But if the nail is a good shape, it's well fixed, then all you have to do is put two lag screws, and that's it. Nothing else, which you can do percutaneously. Then let me introduce the concept of reverse dynamization. Veda Gatt is a scientist based in Dallas in the United States, and she has promoted. It is nothing new which we knew about it, but she did a lot of work, and she's promoting with a lot of her animal work for the last 10 years that we must follow the healing pattern of the bone. we must not allow stiff fixation in the beginning, but in fact, we allow more motion in the beginning. And then as the fracture heals, we need to stabilize. We need to change the stiffness from low mechanical stiffness to the very stiff as the fracture heals. So this is completely different what we currently practice and believe. And there's a lot of animal evidence, and she has done in the last 10 years, she has done a lot of animal work, and all have shown that reverse dynamization works better. There is only one clinical study which has been pulled out of the journal because apparently the authors didn't pay the journal fee, so it's not available. But I have the paper which says that tibial fractures, they allowed initial macro motion for 4 to 2 weeks with an X fix, and as the callus forms at the 4 weeks, they made it very rigid, and this accelerated the bone healing. And in the dynamization group, it healed in half of the time as compared to standard practice, what we currently practice. So this is a good evidence. So I have just set up a trial where we are looking at standard versus variable dynamizations. It is a reverse dynamization trial. So what we're doing is we are putting in a frame in a standard tibia, and we make it a stiff frame. And as the bone heal, we are dynamizing as we do in our current practice today. As compared to the other group would be, as I put in a frame, I allow 3 millimeter of motion in the fracture. I leave it for about 2 to 3 weeks. And at first signs of callus, around about 3 weeks, I lock them and take out all motion, make it stiff, or change it to the rods and leave it for the rest of the duration of the frame until it fully heals. So this is very different, completely opposite of our current practice. And if you go back to our original mechanism, how we practice and what we do. So here, I'll go through it again. Bone heals, it bleeds, proliferates, callus, remodel. Strain-wise, 100% in the beginning, and as progressive stiffness, it becomes more stiff. What we currently practice is stiff and dynamize. We don't want to do that. What I want to do is we allow controlled macro motion here when there's a strain is low, and when we can when there's in the proliferation phase. And as it gets stiff and the callus forms, I will make the concept, the frame stiff. I will lock the dynamizers, eliminate all movements, and leave it stiff until it heals the stiff construct. And this is how we need to protect this callus. This callus is not a normal callus. It can be damaged. Even if we don't protect this callus, there's a risk of non-union is higher. Now, in a normal practice, most of the bones heal, so we don't need to worry. But we need to look at every fracture differently, and in the process of healing, we need to look at it that do we need to protect this callus, and if we need to, we need to make it more stiff, and we need to look every patient, every fracture, every healing differently. Every patient should be looked as an individual. And this is some of the other work published in Journal of Limb Lengthening and Reconstruction. And what they suggest, again, the same concept, flexible fixation in the beginning and rigid fixation as the callus heals and the hard callus forms. It still needs to be proved in the clinical practice. Animal studies is fantastic and logically makes perfect sense. And we actually practice in a lot of ways in the dynamization, but we don't have the evidence as per se. And then the question comes in, how many things we do in a daily practice which are 100% evidence-based? Most of things we don't have evidence. We practice on the basis of logical and science as we understand. And the circular frame is the only device which will allow the reverse dynamization. In addition, it respects biology, gives you stability, and gives you small footprint, and it can be customized to individual patient, and it has a variable stiffness. Everything what we need is in the frame. But still, don't put a frame in a femur or humerus or in upper limb unless there is a need for that. Because patients don't like it, it's uncomfortable. There are better devices we can do that. And as we're changing our practice, new devices are coming in, and we can change the mechanical environment with other devices in a day case basis in the percutaneous method. And so what is the implant choice if we do that? So if I have to summarize it, what is my implant choice? When we do an internal fixation, consider strain. We consider biology, but in addition also consider strain. See that how we can, as compared to fracture configuration, we can optimize strain to give the best chance for this bone to heal. The downside is in internal fixation, your strain is static. We cannot change it. So as fracture heals or not heal, we need to put screws, we need to put in something to the local environment here. And this we should be prepared to do it in an early stage rather than late stage. And because if you do an early stage, you can do percutaneously as a day case, like putting in a lag screws, putting a small plate, all those kind of things. If you leave it late, you might have to do much bigger procedure. Circular frame, as I mentioned, you can customize to patient, and the stiffness can be altered. This is the biggest advantage, and therefore we can do strain optimization. We can increase and decrease it as the fracture needs, or the bone healing needs, and this is the best and the critical part of it. And to summarize the non-union concept, we don't need to bone graft non-union every non-union. We need to look at the non-union personality, that what is missing, what we need to optimize. It is a non-union. What is the reason for it? The cause for it? And what we can do to change the non-union personality in relation to the patient personality for it to heal the non-union. It does not need to be bone grafting. It needs a strain optimization. The dynamization of a nail can be counterproductive. You need to look at it. Will the dynamization work? It will work in some patients, but not in all patients. We need to be careful, look at it, each patient, and see what it will do to the mechanical environment and the strain at the non-union site, and then make a decision. Bone grafts, do you really need it? I say no. Apart from gap non-unions, I don't think you need bone grafts, but it's very hard to change a current practice. And for reverse dynamization, you put in stiff construct first, flexible construct first, then make it stiff for the rest of the healing. And we need to look at it that the construct is not too stiff, and the frame always works better for it. It's the biology, the reduction, the mechanical environment, all the basic concepts must be respected. And as Master Yoda said, the more we learn, the more we realize how little I know. And the more I read, I realize that I'm so illiterate. I know nothing about bone healing. I know nothing about fractures. And I don't know whether I'll learn enough, but we must all make an effort to learn more and get better and give best service to our patients. And I'll like to also invite you, extend my invitation for the Hull Deformity course, which we hold every year in June in Hull. It's a 5-day course. 3-day we do at deformity, and then we do subspecialty. And this year it would be live, free of cost to all of you on YouTube, and I'll talk to Raj TV and OrthoTV. I haven't spoken to them to do a live telecast on a Friday, 10th of June, for everybody, free of cost. But also I have to say this year's course is already full, so we can't take any face-to-face, but you can join on a Friday in a free course on a live telecast. And if you want to come to next year, please either log on to the website to get this address or let us know. Thank you very much.
you very much, sir, for your magnificent presentation, and that was a highly informative presentation for all of us. Now, I would like to request Professor Mofakhkharul Bari sir to share his knowledge regarding the presentations. Please, Professor Mofakhkharul Bari.
Thank you. Thank you very much. Thank you, Hemant,
Thank you.
for elaborating everything, particularly the strain theory and atrophic non-union, and regarding the hypertrophic non-union. And you have elaborated everything regarding the bone contact, reduction, remodeling, stiffness, and of course the dynamization. Still, we have a controversy regarding the dynamization in case of tibial nailing and in case of femoral nailing. What is the ideal time? My question to you for dynamization in tibia and in dynamization in femur. And lots of people, most of the orthopedic surgeons, they don't follow the proper time for doing the dynamization in tibia after doing the interlocking nail in femur and tibia. What's your comment regarding this?
So dynamization is a flawed concept. If you ask me, it should rarely be done. Dynamization does not help bone healing. Dynamization, if it heals,
yes,
if you dynamize and bone heals, it is the time you have given to patient. That is reason the bone
yes.
heals, not because of dynamization. If you leave that bone another 3 months, 6 months, it may have healed anyway. Dynamization makes no difference. What we need to look at it that what this fracture needs at 6 months, why is not healing, and that we need to optimize. It is usually the strain which we need to optimize to give it. And I say in most cases you need more screws than removing the screws. Put in a small plate. If it's an oblique fracture, put 2 lag screws. Not every case is the same, but most of the cases you can optimize the strain and let it heal. So you do not need to dynamize in any case, in my view.
And regarding the scaffolds that you rightly mentioned, biocompatibility, I 100% agree with you, osteoconductivity, and at the same time, the bioactivity. This is the scaffolds. And reverse dynamization, just like in you for me, this one, reverse dynamization. You told that lady from USA, she was working with this bone healing process with the reverse dynamization. And regarding the internal fixation that you mentioned, number one, you always told in your lecture that you must consider the strain and strain. The strain theory is very important for regarding the internal fixation. And regarding the non-union bone grafting, you told that bone grafting is not all the time, but if it is the gap non-union, then you can go for bone grafting or you can go for bone transportation. So your lecture was very good. Thank you very much for sharing a good knowledge to everyone. And thank you very much again.
Thank you.
Thank you very much, Professor Mofakhkharul Bari sir. Now, I would like to request Professor Omar sir to share his knowledge. Professor Omar sir, would you please? Sir,
in his presentation.
Yes, sir, please.
Yes. There's one thing in my mind. I think preservation of the blood supply is very important for healing purpose of the bone, especially in some localities like even in our country. Why the bone setters still they are dealing with the bone because they are preserving blood supply. So the only thing there may be malunion. So instead of screws which you are using, this is a choice. Usually I am doing olive wires without opening the fracture site. I can translate the fragments of the bone and to put olive wire in the safe corridors. I don't know what is your opinion about this one. And the second thing, in atrophic non-union, is it essential almost always to excise the bone till there is paprika sign or just by compression? Because I face some cases just by compression and bone transportation, there will be healing process. Thank you so much.
So your atrophic bone union, it depends. You need to have bony contact.
Yes.
And at the end of the day, the resection of the bone, actually, paprika sign, the vascularity is not a problem as such.
Yes.
So you don't need to resect a lot, and you don't need to resect at times. It is what you need to do is improve the bony contact. Now, if your bone edges are sclerosed, then there is no biological activity there. It's not because there's no activity, but it is not happening. And I think so that is important, that if you shave the small bit, it's not a excision, it is that bit. And I think at the end of the day, it's a very hard to say because each case is separate, but generally the resection is minimum, is hardly any actually. It is a bony contact which is important. And I couldn't understand your first question.
Instead to apply 2 screws, we can use olive wire on the safe corridor, and we can translate the bone in different directions till there will be more compression between the fragments. So what's the idea about that?
So it depends where you're doing it. If it's in the tibia, you can do that. In femur, if it's a patient has a frame, you can put but olive wire will never produce the same amount of compression as a lag screw. Never.
Yes, okay.
Because the pressure it creates, it will create the bone necrosis, and you lose your pressure very, very quickly. Because bone responds to the mechanical environment, and the pressure of the bone will what will happen, there's bone necrosis. So lag screw actually pulls the distal fragment and put it together. So lag screws are better, but if you have a frame, even you can still do the lag screw. So personally, I don't think the olive wires will provide the same thing in a non-union. If it's a fresh fracture, then what you can do is you can bring the olive together you can have a pull-in olive, compress it, but then I would suggest change the wires, because if you loop the wires with the same amount of pressure, they will get necrosis. So put 2 olives, compress it to new olives, and take out the original ones, because the pressure on the original one is too high.
Thank you so much.
Thank you very much, sir. Now I would like to request Dr. Shamsul Huda, sir, to share his knowledge. Dr. Shamsul Huda, sir, would you please?
Yeah, thank you, Dr. Tanvir. Sorry, I'm traveling, so I don't know if my network is clear. My voice is clear, Dr. Tanvir?
Yeah. Absolutely clear, sir, please.
Yeah, welcome, sir. Hemant, sir, and thanks for such a wonderful talk, sir. I couldn't hear it properly. You just cleared all the concepts of non-Indian healing, mechanical access. These are all very important points, and I really agree with you at many points. Just one or two more queries. That my first question is that, like you put on plate over nail in case of fever. At times we apply circlage wires, and gives circumferential stability. So what is your take on that, sir? Place of plate, and we apply circlage wires. I do that, sir. Get a very good healing.
So the problem with the circlage wire is it will never give you the same amount of stability. Never. And the second problem is when you put the circlage wire, you have to vascularize area all around the bone. So in a way, it is actually will damage the vascularity, and it will not provide the same thing. So the fracture is oblique. So if there's an oblique fracture, there's a shear, and your circlage wire will never counterbalance the shear. The only way the shear can be balanced would be in screws perpendicular to the plane of the shear. So either you put 2 leg screws or a plate to prevent that. So I don't think circlage wire would do the same thing.
Right. So one more question, sir. In place of if you put rings, instead of pushing out screws, can you just not put olives and give compression and give accordion method? That gives a very good unit.
I think accordion method is a system which provides you an optimum mechanical environment. So I'm not saying that what device you use, but what I'm saying is that whatever device we use, we must optimize the mechanical environment. And if you feel that the frame would be best for this patient, then that is the mechanical environment. But the important thing is we need to provide the right mechanical environment for bone healing. Now, if you think you can provide a plate then that's fine. Sometimes you have to put 2 plates in the femur, right? And sometimes you will find, I get patients who had a long plate on the femur and about 3 locking screws very close to the fracture, and the construct is so stiff. So what I do is I go in and take 2 screws out actually.
Right.
So what I'm saying is that, so it is, the device is important, absolutely, but the purpose of the device is to reach the end goal of fracture union or bony union. Now that can be combined, used on its own, but the way it is that the process is the same, that we need to optimize the mechanical environment of the bone.
Rightly, I agree, sir. Thanks a lot, sir. And again, sir, I welcome you on behalf of, as Joint Secretary of Assam India. Welcome for tomorrow's talk in Assam India. We'll be meeting there, sir.
Thank you very much.
Thanks a lot. And on behalf of OrthoTV, sir, I assure you that we'll be making your conference live, sir, on that day also, sir.
No,
Thank you, sir.
Actually, while you are there, can you contact the Ortho and Raj TV to contact me? You've got my email address, because I was planning to talk to them that Friday 10th for live telecast.
No issues. We'll do it, sir. We'll do it, sir.
Okay.
Will do, sir. No problem, sir. Definitely. Both Raj TV and Ortho TV will telecast your program, sir.
Definitely, sir.
Sir, I have one last question, sir.
Go on.
In case of
As
oblique
many as you
fracture,
like.
yes, sir. Thank you, sir. In case of oblique fracture shaft of femur, then what implants will be the best choice? Interlocking nail with interfragmentary screw, or DCP with interfragmentary screw, sir?
So if there is any comminution, it is a type C low environment fracture. So you can put in a nail, it should be fine, because it will, but your nail has to be quite decent nail. Now, so the nail at that point should be fine, because it will counterbalance the shear. If you think the shear is too much, you might put a lag screw, and then it will provide you the, it becomes a neutralization device. So you can do that. Equally, if your nail is good, comminution is not too, then you can hold it. But you should be prepared in 4 to 6 months to look at it, that how's it healing. And I'm telling you all this, but if you see, the vast majority of the fractures still heal despite when I practice. The non-union rate is about 5 to 10%. So the question is that what I'm saying is, because the reason is that we don't understand it very well. So I'm professing all this, but actually in true sense, we don't understand it very well. We don't understand how much strain we need, what we do, but we work it around in a system so that we optimize it from a current understanding. So so in your current practice, if you use a decent sized nail and see, there's a good practice, as long as it's stable. But what we need to do is, we need to be careful in 3 to 6 months, keep an eye on it and see what is the mechanical environment and does it need changing now. If it is healed, no problems. But if it doesn't heal, and if you feel in the beginning that mechanical environment is not correct, then putting in a lag screw is an absolutely right thing to do. It's not a problem.
Thank you very much, sir. Thank you for giving a specific guideline in a very difficult case. Thank you, our honorable academic faculties, for being with us. And thank you, Raj TV and Ortho TV, for helping us to telecast this program. And I would like to thank the Malias ENT Specialized Hospital for sponsoring our program. Dear viewers, I hope we will connect you in the coming Friday with another magnificent topic and a speaker. Until then, I am Dr. Tanvir saying bye-bye to all of you. Bye-bye.
Bye-bye. Bye-bye.
Bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.
Okay.
Okay. Thank you, sir. Thank you.
Thank you, Hemant.
Thank you, sir.
Thank you.
See you.